It is now nearly 8 months since I started doing phaco with my non-dominant hand, that is the left hand, for issues of managing astigmatism. And now I am going to present this case in which I have achieved a level of perfection. So this was a lady who was planned for cataract removal in the left eye, and she opted for a trifocal lens. This is the fundus photograph, and this is the workup case sheet of this patient. And as I usually use my SRKT formula and also apply that formula for my UV2 counterpart so as to be very accurate about the IOL power calculation, and this was how it was ended, that hydrophobic trifocal was planned for a power of 21.5 diopters, and additionally I also take into account the amount of corneal astigmatism. So this lady had 1.5 diopter of astigmatism, for which opposite clear corneal incision was also planned, because usually my incisions induce 0.5 diopter of astigmatism. So aiming for our residual 0.5 diopter of astigmatism, this surgery was initiated. So as we will go ahead and see that this incision is being made at 70 degrees, which is the steep axis, and later on at the end of the surgery we will place opposite clear corneal at the same meridian. So going ahead using my left hand to make this corneal incision, which I have found to be the one of the difficult part, because then I also realized that the blade has to be in a very perfect condition in three-dimensional space so as to have a perfect incision. So those who aspire to switch to left hand or the non-dominant hand have to learn that incision making, and second most important difficult task is switching to the non-dominant hand capsulorhexis. But audience who are looking at this video will agree that I am doing a good job here by making a very consistent and a very round capsulorhexis with my non-dominant hand. So it took me about something like 8 months of continuous practice, not actually continuous, but yes, whenever it was required for me to make an incision in the superionasal quadrant of the right eye or the superiotemporal quadrant of the left eye, I didn't switch my position, rather I used my left hand to do the surgery. So what I also want to propagate a message that those who want to switch to their non-dominant hand, it is just a matter of taking that initiative and switching to your non-dominant hand, and some amount of practice will make it happen. So here we can see it's a nice round centered, I would say a perfect rhexis, and this is the side port for which I routinely use 23 gauge MVR blade. So all the steps are being done with the left hand because that is the convenient position for myself, sitting at the head end of the patient and using the left hand to manage this cataract with incision at 70 degrees. Now you can see there is some amount of conjunctival bleb formation because of the reflux, but that should not matter because I should be able to finish my surgery within the given time by the time there is significant chemosis of the conjunctiva which precipitates. So rest of the things, I find that the nuclear disassembly is not as difficult as one would anticipate, and it is very much possible to use your non-dominant hand and do the chopping and emulsification of the nucleus. So at times I do complete chop of the pieces, and at times I start consuming them as soon as they are formed. So here I have chosen to start consuming because I could see there was little difficulty in rotating the nucleus. So this was the most easiest aspect or the strategy which would have worked. Again, as we can see, the rotation is not possible, so I'll start consuming it from whatever quadrant is presented in front of the phaco tip. So I will just repeat again that if you want to switch to your non-dominant hand, nuclear disassembly is usually not a troublesome step because we all have been using both the hands during phacoemulsification. It's just that the situation changes, that the active hand, that is the chopper, and the handpiece, they are switched. So usually we are always using both the hands during this maneuver. So that is not very new, it is just that the roles have changed. And one thing to remember is that you have to pull out your chopper first, which is unusual because usually you are pulling out the left hand instrument first if your dominant hand is the right hand. So that has to be remembered. The nucleus and epinucleus have been removed, and now we are proceeding for removal of the cortex. And here I have found that it's very important to keep track of the aspiration port, because one of my earlier videos I have demonstrated that unwanted and unmonitored too much turn of the aspiration port towards the posterior capsule caused a posterior capsular tear. So there are a few things which you have to relearn, otherwise you may end up into complications. So one has to be very observant about the port which is aspirating the cortex, has to be very much in view, and that has to be very keenly monitored. Usually it is the subincisional cortex which causes problems, but again with experience I have learned to manage it well. So the cortex is now removed and we are proceeding for implantation of the proposed trifocal hydrophobic IOL, which is from the company Care Group, and I find that their IOLs are not only very reasonably priced, but they are also very good at performance. So as we can see, there are markings on the IOL. This is a diffractive IOL, but surprisingly the trifocal IOL has less markings or less circles compared to a bifocal IOL. Placing the opposite clear corneal incision. So this is the step where I want to do this, that is when the irrigation cannula is inside and the irrigation is on, aspiration is off, and the eye is turgid. And not only this provides me good intraocular pressure and a turgid eye for making the incision, but it also gives me a very good clue about placing the knife, because if I place my irrigation cannula straight ahead radially into the anterior chamber, it gives me a very good clue where to place my knife and which direction it should go. So here we have finished the surgery. We are forming the anterior chamber, sealing the wound by hydrating it. And this is the first post-op day picture, where we can see the pupil is slightly dilated, the cornea is clear, the IOL is well centered. And this is again a photograph showing the concentric rings of the trifocal IOL, and we can appreciate that the ring is bang on the pupillary center also, and this will definitely help in having the optimum optical effect of the trifocal IOL. Now this is the picture at 7 days, and at this moment I am so happy to tell that this patient had perfect vision, that is 6/6 for distance and N6 for near unaided. And the astigmatism which was there, 1.5 diopter of corneal astigmatism, we had a residual of 0.5 diopter of residual astigmatism, and probably it helped in having better vision. Thank you.